Oh, we don't have it. Okay. So I'm Holly Hackett. I'm with Medicare for All Connecticut, and you guys may know me from other organizations as well, but this is one of my favorites. So it's nice to meet you all for those I don't know. And I'll popcorn it to Denise.
Hi, everyone. I'm in Windsor, Connecticut. My name is Denise Hart, and I'm involved with several different organizations, and I'm glad to be a part of this one.
Who do you want to pass it to, Denise?
I'll pass it to Sheldon.
I am Sheldon Tubman. My title is litigation attorney. That's at Disability Rights Connecticut, which is a statewide advocacy group for people with all kinds of disabilities. And I do all kinds of advocacy, not just litigation.
Yeah. You have to pass it on, hon.
Oh, sorry.
That's okay.
So to Bill.
Yeah, Bill Marico from New Haven. I'm retired state employee from the state controller's office, where I managed health insurance for state employees like Stephen. Now chapter treasurer for chapter 405 of State Employees Association, New Haven area, also on the executive board of the Alliance for Retired Americans, and on the board of the Fairhaven Community Health Center. I'm involved in Medicare for All since 1974.
All right.
The original act.
Yeah. And who would you like to send it to, Bill?
Kate Powers.
Hi, I'm Kate Powers from West Hartford. I'm a member of the Greater Hartford Immigration Coalition, and yes, we've been quite active with representing immigrants in court. Interviewing them, getting their stories, helping them fill out the forms. And then supporting them afterward too if they're in businesses, hiring them. Helping them find medical care on an individual basis, all sorts of good things. I have been supporting Medicare for All and going to rallies at the Capitol for a few years. Recently, I had an accident. I was stepping off a curb in a very, very dark area, and I misjudged the depth of the curb and wound up with a couple of fractured pelvis. And I realized that if I were an immigrant with no health care, I could be brought back into my house, and 3 days later, I might be dead. 3 months later, I'm almost fully recovered. We see so many disasters with immigrants with big health problems.
Yeah.
Oh, and I discovered another resource recently. If you know anyone who needs physical therapy, I found out that UConn does a pro bono program.
All right. Wow.
So does Quinnipiac. We were chasing down medical care for the immigrant that I sponsor, and we'd worn out a few other options with Trinity Healthcare, and then we found this. Wonderful.
That's great information.
it.
Thank you so much. Yes, please.
Oh, quite welcome. Rana.
I'm Rana. I'm from New London. I get involved in a lot of things, but maybe about 5 or 6 years ago, I became involved with Medicare for All Connecticut because it seemed like healthcare just impacted everyone in so many ways that it just seemed like a no-brainer to work on that. So I'm part of this group, and I'm happy to still be here, and not happy that, seeing how hard it is to make progress. I'll pass it to Zach.
Sure. Yeah. Stephen Monroe Tomczyk. Everybody calls me Zach. As Bill said, I work for the state. I work for Southern Connecticut State University as a faculty member in the social work department. And when I'm not teaching, which I'm going to have to run out and do pretty quickly, I have a class tonight. I'm doing all kinds of activism, including activism around trying to assure a basic human right to health care. My view is basically consistent with Roosevelt's Economic Bill of Rights. That's what I teach to my students all the time, and I try to live it out as much as I can. So that's why I'm here tonight. I wish I could stay the whole time, but have to run out. And am I correct? I know you haven't gone, Holly, right? So
I did. The only one left
did.
is Margaret.
Margaret. Okay, I'm always very bad at this stuff. Thanks.
That's
Okay, so it's
okay.
Margaret.
You're good.
Thanks.
Hello, this is the first of these meetings that I've been a part of. For some totally unknown reason, I received an email notifying me of the meeting this evening, and I figured I'd check it out and see what's going on. I live in West Hartford. I'm a retired criminal defense lawyer.
Welcome.
Thank you.
Welcome, Margaret. Thank you for being here.
Thank you all.
Now, Sheldon is going to be our speaker this evening, and he's going to give us an update on what's happening and not at the legislature this session. Go ahead, Sheldon.
Well, and be more specific, since there's all kinds of things happening and not happening at the legislature. I think we're going to limit it to things that affect lower income people with disabilities. How about that? Is that fair?
Yeah.
Then it's much
Perfect. Yes.
more manageable. So the big overall picture, which I mean, this is, and I apologize, some of you know this really well, but for some who don't, the big overall picture is that our state budget is in great shape. We have major surpluses. We have a hugely overflowing rainy day fund. So we've got really much more than we need. But the problem is we can't spend it. And we can't spend it because of what the legislature voluntarily did to itself by saying, well, we're going to tie our hands. And we're going to tie our hands so that we have a bunch of caps on spending that have nothing to do with how much money we have, but rather they're arbitrary caps. And the most significant one is the spending cap. And the spending, I mean, they're all spending caps, but the one that's actually called a spending cap is the most problematic one. And that's the one that says you can only spend the same amount you spent last year plus a small adjustment. And it doesn't matter that, yeah, but we've got so much in surplus and so much in savings and excess savings and, where we're flowing. Yeah, but you spent that much, and so you can only spend that plus point whatever it is, small inflation factor. Now, these caps are all waivable. They all in each case, there's a means, and sometimes more than one means, for overriding them with consent of the governor and a certain percentage of the population. It may be of the legislature. It may be super majorities, not the usual 51%, but you can still override them. The problem is not having the political will to do that, and particularly the governor being not only not having the political will, but being opposed to it. And on the grounds, what he says is we have to be fiscally responsible, that we were fiscally irresponsible for so many years. And because we were fiscally irresponsible, that's why we kept running out of money, which is true.
Right.
And that part of it. And therefore we, got in trouble and we had to deal. We had to raise taxes and blah, blah, blah. So we can't go back to those times. We have to be really, really fiscally conservative so that we make sure we're okay for the future. And the result of that is, sorry, we can't spend hundreds of millions of dollars we have. And so every group that wants to get something passed in the legislature that costs money, this is a problem. Nevertheless, people testified before the Appropriations Committee which is the big committee that does the money stuff, early on in February, saying, testifying on their various issues, which would cost money, and also testified at various other committees where the subject matter bills came up, to testify in favor of the thing specifically. But again, you talk to the Appropriations Committee about the money for it, and you talk to the Substantive Committee about why the policy would be a good thing. And that's the way we were doing it. Everybody knew about the spending cap, and everybody knew it was a real problem, and that the governor was saying, I'm not going to bend. Well, what was announced last week was that, unlike every year in apparently everybody's memory, like everybody, the way it works is that we have a short session and a long session. And during the long session, we do a biennial budget, 2 years. Then every other year is a short session. And we do a shorter period of time. And we already have the 2-year budget, but we do adjustments to the budget. And that's what the proposed budget is always called, proposed adjustments to the biennial budget. And then we fight about that, and then we make various adjustments, and then the legislative leaders and governor fight about it and negotiate, and we have a resolution for adjustments to the 2-year biennial budget. It's done that way every year, every 2 years. That's the way it's done. Not this year. This year, the Appropriations Committee, after having all these hearings, and after hearing all the stuff from the governor, and then hear the complaints and whatever else wants, instead of doing what they always do, which is to put out a proposed budget, which shows the distinctions between their budget and what the governor said and why, but they're doing it, blah, 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 making everybody happy, making some people very happy, whatever. They said, oh, never mind. We're just not doing anything. We don't have to do anything because we have a biennial budget, which is good for 2 years, right? We don't have to adjust it. That whole adjustment thing, though it's always been done forever, and nobody remembers otherwise, we don't have to. We're not going to. And we don't even know what the real strategy is in this. It may be a hardball strategy where the governor also proposed budget adjustments and he's not getting any of them. And it's a way of bringing him to the table to be willing to adjust on these fiscal guardrails. We don't know that, but that's a possibility of the strategy. If it is, will it work? I have no idea. But anyway, that's why we are where we are now. The Appropriations Committee completely punted, said, forget it, we're going home, and we're not doing anything. And in the statement that they issued when they did this late last week, they said, we are going to leave it to the leaders, basically, legislative leaders, to negotiate with the governor. Does that mean we're going to try to get the fiscal guardrails blown up? Nobody knows that either. So the pressure has been, and even after this announcement last week, still is, to put pressure on the governor because he's the real problem. He's a Democrat, theoretically. The two houses are both run by Democrats. If he says, we can't, this is ridiculous. We can't let these needs go unmet just because we like our little fiscal guardrails. If it's really excess money that we don't need right now, I mean, we really have excess. We can spend it, or at least some of it. He won't do that, and that really is the obstacle. So that remains the obstacle, and what when I say we, some of us, which includes Holly, have done, is organized a rally next Thursday at the Capitol outside with the theme, well, the title is like disability rights and justice, but nobody knows what that means. So it's about adequate funding for certain needs, healthcare needs of people with disabilities. And there you go. And the 4 issues are listed there. But you see the big headline is away with the guardrails, denying us these things. The 4 things, I mean, probably some of you know what these are or know what one of them is or something, but I'll quickly go through what the 4 issues are. Mental health peer-run respites are an alternative to involuntary psychiatric hospitalization. So that's a very, unfortunately common thing that happens. And when it happens, the consequences can be quite obviously disruptive to the individual, but also maybe not good long run. And peer-run respites are a thing that's been tested and successfully, such as in Massachusetts, our neighbor to the north, where they have several of these, and they are, like it says, peer-run respites. They are run by people with mental health conditions or a history of mental health conditions who have worked through their issues with help from others. And the idea is that this is a respite you keyword is voluntarily go to get help from people who understand where you're at and don't judge you, but try to help you understand where you need to be, and ask whether they can be helpful to you and provide guidance based upon their own experience, at a far lower cost than involuntary psychiatric hospitalization. I think the plan is there's a bill on this that would be 8 facilities, and I believe the cost was a little over $8 billion estimated for that, through the Department of Mental Health and Addiction Services. Husky C without forced poverty. What this is the Medicaid program is very complicated, and I think it was Zach who said, I guess he's gone now, but that our Medicare for All makes a lot more sense than our broken system and fragmented. Well, I am one of those people who lives in that terrible space of trying to improve tiny little interstitial little pieces of the mess, and specifically in the Medicaid program. But basically, the Medicaid program is a state and federally funded and state and federally administered program that provides fairly broad coverage for health care for almost all low-income people. Not all, because specifically, of course, we have immigrants who are not any immigrants, but immigrants who are undocumented or here less than 5 years. There's a problem with that. But overall, Medicaid is a program now since the Affordable Care Act for all low-income people. And then it's broken. It has different names, different pieces of the Medicaid puzzle, and the main ones are Husky A, C, and D. Husky B is not Medicaid; it's the CHIP program. We'll talk about that. But Husky A, C, and D are the main programs. Husky A is for families and kids and pregnant people. Husky C is for elderly disabled people. Husky D is miscellaneous. That's what a result of the Affordable Care Act resulted in the Medicaid expansion, which for the first time didn't require you to be in any magic category, just be an adult and be low income, end of story, and not even assets don't matter. That's what the Affordable Care Act said, told all the states they had to do, and there's a Supreme Court case that turned that mandate into an option, which is a real problem still in 10 states, but ours is one of the first states to adopt it, and that has broadened coverage. Now, the Husky D income eligibility is 138% of poverty, which is not a lot of money. I think it's around $1,700 now. But the Husky C limit for elderly disabled people is much lower, which is discriminatory, and there's no basis for it. You could say, well, isn't Husky D reimbursed by the feds at a higher amount? Yes, it is. 90 cents to the dollar versus 50 cents to the dollar. But you know what? So is Husky A. Husky A is reimbursed only 50 cents on the dollar too. And that goes up to 160% of poverty for adults. So what gives here? It's just kind of raw discrimination. And it costs money to fix it. So we have been working, Holly and I and others, for just 2 years now. It's our third year at the legislation, to get the income limit increased to at least match Husky D, and also to get rid of the asset limits. Husky C is the only full Medicaid program that even has any asset limits. As I said, they're illegal in Husky D. Husky A, we got rid of them. Why do we make elderly disabled people have to live under the asset limits, which are incredibly low? $1,600 for one, $2,400 whopping for a couple. So you can't ever get out of poverty. We would like to address both of these things. And so We advocated for it last year, and we actually got it. We got the income increased to even go beyond Husky D a little bit. We did not get the assets fixed, but we got the income fixed. The problem on this issue, though, is that they did not appropriate enough money to cover it. So the governor came in this year at the beginning of the session and said, "Oh, we want to adjust the law to reflect how much money we have, how much money we appropriate. Forget the spending cap, and could we put more into it? But how much we did appropriate doesn't match the law is passed. So let's mess with the law rather than just okay, let's put up some money to cover the law you already passed." No, they want to repeal the law. It was passed last year, and that's the big fight we have. So again, this involves money. The third issue being heard is people who use wheelchairs. This is actually not a problem necessarily of poverty, though usually it is. And that is that the industry, the wheelchair supply industry, like the hospital industry, the group home industry, and a lot of other healthcare related industries have been glommed onto by private equity. People have heard of private equity. And private equity is in general a very destructive force. So in the wheelchair supply industry, which I've been around a while, and I used to advocate and still do for people who need various kinds of medical equipment under Medicaid. And the suppliers were small mom and pop operations. Literally, I knew the mom and the pop, and they provided decent care to get people's wheelchairs fabricated, custom wheelchairs made, and then maintained and repaired as needed. And this was a very good relationship with their consumers. But what happened with private equity is they started gobbling up all these small mom and pops and became huge. And now the industry is dominated by just two companies that control. And because they're private equity, they're always looking to cut costs. And that's what they've done. So they've stripped out a lot of the employees, and they just don't have the staff, literally the mechanics, to fix the wheelchairs. So people wait weeks and weeks for wheelchairs. And if anybody who uses a wheelchair, you know that wheelchairs are really an extension of people's bodies. They give them fundamental freedom, and in some cases allow them to get out of bed, allow them to get out of the house, allow them to go to medical appointments. But also, without a proper fitting wheelchair that's functioning well, you also run a risk of serious medical complications such as skin breakdown, decubitus ulcers, which can be fatal. And then you have other medical consequences that can result from poor alignment. So these are really serious issues that affect really fundamental qualities of life, more than quality of life, basic independence. And there's a real need to address it. And part of the way to address it is through the Medicaid program, where we can reimburse for certain things that are not being reimbursed for now, make the companies more willing to do it, but also to get rid of things like prior authorization. Why do you have prior authorization for a repair of a thing that was already prior authorized and approved, and now it's broken? Does that make any sense? So that's part of what we need to do. The other part we need to do is to directly regulate these private equity owned companies and mandate timelines for fixing the thing. So they just have to hire the staff. They don't want to do it, but sorry, it's going to eat the profits, but you can make them do it. But there's a cost to this. There's the cost of regulation, and then there's the cost of Medicaid changes. The last issue is accessible diagnostic medical equipment. Also, generally, people use wheelchairs. That this issue affects them, and that is, it's not well known, but it's shocking that people who use wheelchairs are routinely denied the ability to get weighed. They're routinely not able to be examined. They're routinely not able to get mammograms or x-rays or MRIs because we just don't have the equipment for that. So well, but how do I get screened to see if I don't have breast cancer? I don't know. Guess you have to figure that out. So there's a massive problem here, and the hospitals are the boogeymen here, and they don't want to spend the money to get the equipment exists. and the standards for what is appropriate accessible equipment has been set since 2017 by something called the U.S. Access Board, which was created by the Affordable Care Act to deal with this problem. And they did, it took them years, but they did come up with detailed specs on all the equipment, all these kinds of imaging equipment, et cetera, and scales and exam tables, so they can be accessible for everybody. So everybody can actually be weighed and examined, et cetera, regardless of the fact you have to use a wheelchair. So the problem is that besides the hospitals don't want to do it, is the fact that one of the hospitals is a state entity, UConn. And so its costs are state taxpayer costs. And so there's a cost. Well, all of these things are all bound together because of the fiscal constraints. I did want to also mention those are the 4 issues for the rally, but there's certainly other issues we really care about related and relevant to what Kate was talking about. One of the bills I'm working on, there's 2 bills that would improve access to health care for non-citizens who are undocumented or subject to the 5-year bar. One of which is a proposal, to increase the age limit for kids to be covered if they're undocumented. Kids are not subject to the 5-year bar, so really it's just about undocumented kids. So there's a proposal to go up to 18. That costs money. Guess what? Heard what happened with the Appropriations Committee. The other thing, which I've been actually working on more directly, is a bill which would expand what is an emergency medical condition. And emergency medical conditions are ones that you kind of would think common sense, but some of you may be familiar with EMTALA, or the anti-dumping law. That's the law that prohibits hospitals from refusing to see people that show up at the ER, right? They've got to examine them and stabilize them and all that. The standards for what is an emergency medical condition is laid out in federal law there. The exact same definition applies to when Medicaid will pay for health care for undocumented people or people subject to the 5-year bar. And those are generally things you'd think of, like, heart attacks and car accidents and gunshots. But there has been a recognition supported by the federal government, well, the current one and the 2 before that, to have a broader interpretation of what's an emergency medical condition. So, for example, 3 years ago, I worked with others in Senator Looney's office, and we successfully got through a policy change at DSS to cover dialysis. So people, believe it or not, until 3 years ago, if you had end-stage renal disease and will die without dialysis or transplant, there was no coverage for you if you were undocumented. I'm sorry. Or even legally here, subject to the 5-year bar. Sorry, we can't help you with that. But we got that covered finally as an emergency medical condition without the person having to show up at the ER on death's door, which is what the cycle is every few days if you don't get dialysis. So that's now officially covered. So there's a proposal. We have a bill that came out of Human Services that would list a bunch of conditions besides dialysis, but also some other ones. And perhaps even more important, it would allow people to apply for this in advance. And some people might object to it, but how's that an emergency? Wait, if you're applying in advance, then it's not really an emergency, right? Because you said, an emergency is like something happens to you, right? No time. Yeah, but something like dialysis really makes the point really well. If you don't get dialysis within several days, you'll be dead. So, it really is an emergency if you go back, a few days. And there's other conditions like if diabetes is uncontrolled, seizure disorders, those kinds of conditions, which will result in death or organ damage brain damage if you don't address it right away. So that's a bill that costs money. And all these bills are tied up in supposedly we're not going to do an adjustment into the budget, and the budget didn't provide for it. You're SOL. Sorry, right? So we'll see what happens, but that's sort of where we're at. I do encourage people to come to the rally because we really want to make a show that a lot of people care about these issues. We'll have some singing, we'll have some chants, we'll have some signs and banners. But we want to make some noise and try to get the governor's attention, try to, I think, back up the legislative leaders who are on our side to, get them to feel stronger in arguing with the governor on these things. But I think that the goal is to put it mostly on the governor because, frankly, that's where the real resistance to spending the money is coming from. Again, even though we have the money. I guess that's where I should end. Does that make sense?
Sounds good to me. Does anyone have any questions for Sheldon?
Guess not. That's fine.
You were very clear.
Well, yes, very much so. Yeah,
Sorry I
please
was
do
late.
come to the room.
I was
That's
just going to
okay,
ask
Pete.
when the event is, because I came on late.
4/18. You want to put it back on, Holly?
Sure, I will. Yep.
Suppose I could have just asked after the meeting, but
Yes. Just, people can see it again.
yeah, couldn't hurt.
Nope. Okay.
Not finding it?
4/18, 1 to 3. Oh, there.
Oh,
Okay. Perfect.
I'm getting there with all this tech stuff. I'm trying.
And we're still looking for images, still thinking about how do we use the guardrails, like a picture of guardrails that, one of the banners we're probably gonna have is like a chains being broken, and in the middle of it says guardrails, breaking the guardrails. But we really want to do it in a very visual way, to hopefully get everybody's attention. I'm not saying it's going to work, but what else are we going to do? They hold all the power. The governor does mostly, and we want to say it's not okay. I did want to say on the Husky Seed thing, our messaging is don't reinstate discrimination in 2024. Wait, we were discriminating against people with disabilities and older people. We finally fixed it. And now, before it even goes into effect, because when they passed it last year, they actually delayed effectiveness until October 1st, 24. Before it's even gone into effect, you want to take it away, repeal it, and affirmatively reinstate discrimination against people with disabilities? That's, people should understand that's what we're talking about because we say we don't have the money.
except we do have the money.
Right. Exactly.
We do. And
Mm.
one of the caps, one of the caps is also the volatility. I said the spending cap is also the volatility cap, which is supposedly to deal with the fact that, there's a lot of fluctuation in rich people. We have a lot of rich people in Connecticut, by the way, if nobody knew that. And so their money is, unlike regular people, is very capital gains oriented, stocks. And so, and other investments. And as a result, when the economy is doing well, there may be booming high returns, and then they pay taxes on the high returns. And so, but then we could have bust times. And so we need to have a volatility cap so to even that out, so we don't go crazy with all the excess money. That's another one of the caps, and these things it adds up to hundreds of millions of dollars that are just sitting there that we're told we can't touch. And as somebody else said, it's like we really, really want to save for our kids' college, and we put money into the 527, but the kid is starving to death because you don't spend the money on food in the meantime. It's kind of just can't afford that. So
It's like you said, don't reinstate the discrimination. And it's always those of us who are people who have disabilities or the older people. It's always us. We always get the cut first, always. And it's disgusting and it has to stop. It is discrimination, and it is awful that it was fixed and he's going to unfix it. It's not good. And it's just annoying now. do the right thing. I don't know. Anyone else have anything? I'm good. I mean, I know this mostly. Um, any other thoughts, comments, anything?
I was interested in the idea of the fiscal guardrails, because we think of guardrails usually to protect people from disaster. And here it's money that's being protected from disaster. But it took me a minute to make the connection that money is taking the place of people here. I wonder if there's a way, if there's a visual for clarifying that so that people will simply have it.
Yeah. Well, that's really helpful. I mean, I don't know what exactly the visual is, but I can say that along these lines, there was a story in the Hartford Courant front page the other day, maybe a week ago, about funding for group homes. So for the workers in group homes, and they really are paid very well. I mean, they're paid like a little more than flipping burgers at McDonald's, and they're not flipping burgers. They're, and so in this article about it, one of the people, a parent of somebody in one of the group homes, was saying they're talking about the fiscal guardrails. Well, I say, what about human guardrails? What about the fact that don't we care about having humans who actually, my daughter, this is what you say, my daughter, like she would, if left to her own devices, she'll go out on the road and get killed, or she'll, burn herself on the stove. And so she needs like a humans to act as protectors, guardrails for her. So that I'm much more concerned about that than I am these economic fiscal guardrails. So it is, yes, but I just haven't been able to figure out. We haven't been able to figure out a picture, I like that does that. And we're looking for suggestions. What's the visual on that?
I wonder if there's a possibility of simply, since we've got the guardrails, we assume that they're on the edges of a road. I wonder if there are, walking dollar bills with heads and feet, and I wonder if there's also maybe the people who are on the other side of the guardrail, the people who aren't being protected. I don't know. That's
Right.
Hmm.
Well, but we're working on it. Our next meeting is tomorrow at 9. This
Good,
planning
good.
is correct. So we're looking
Good.
for ideas. Thank you.
The
Just-
sad part is they don't realize we're all going to become senior citizens if we're lucky.
Oh, some of us
So
are there.
might cut 'em.
Yeah, a
Some-
lot of us are
yes.
there.
Right.
Yeah.
So just
Yeah, I'm there.
related to what Sheldon said, there is also a study that was last year, the legislature passed a bill to have DSS do a study of Medicaid rates for ancillary providers, for specialists, and for community health centers. The half of the study for ancillary providers and for specialists has been done. And this study showed that those providers are drastically underpaid.
Mhm.
The study for community health centers is still being done. We know they're very underpaid, but the study for the specialists and other providers shows they're drastically underpaid. So the bill in the legislature this year is to say, okay, let's fund that. Let's put those rates into effect. DSS and the governor are saying, oh no, we have to wait till the whole study is done. So next year they'll have the same damn thing. These rates would improve the possibility that people on Medicaid could get services from specialists if they're paid more decently. So, but DSS is refusing to do it at this point. So
Because the governor has said that we can't spend any money because we have these fiscal guardrails that
Right.
can't be violated.
Right. The other part of the guardrails, of course, you mentioned about the group home workers. The reason the group home workers are so underpaid is because 20 years ago, the state, I worked for 1199, by the way, before I worked for the state. We represented state group home workers, right? And the state said, well, we have to privatize everything. So they privatized everything. And the privatized people are still making less money now than group home state workers were making 20 years ago. Absolutely crazy. So the CEO of not this is one of those circumstances where the CEO of Oak Hill and the union are on the same side saying you have to solve this problem. And yet the governor is saying there's no money. So that's all one big struggle.
Yeah.
The other part is the higher education funding, which is another part of it.
I thought they were letting that part go through. No, huh? All right.
Well,
Well,
unless something happened in the last 2 days.
okay.
It violates the spending.
Yeah,
So-
okay.
I guess there seems to be the will to do that, but
Yeah.
again, okay, and how's that going to work?
Right.
Okay. All right. Well, now on that depressing note, but hopefully if we continue to shake things up and we continue like embarrassing perhaps, Sheldon's word, not mine, perhaps we will actually get somewhere, because obviously doing things the right way has not helped, and trying to advocate in the right way has not helped. And if our legislative leaders are actually on our side with all these issues, why can't the governor get on board? I thought we put those people in place, our legislators. They legislated what we asked them to do, and the governor will not allow it to happen because of arbitrary guardrails when we have so much of a surplus. I just think it's ridiculous. So things need to change. But I think I can give everyone back 12 minutes of their life if nobody else has anything else they would like to ask, or if there is no other comments.
There's no
I-
basketball tonight.
Oh, there is. I'll
There's no
take about
basketball
3.
tonight.
Yeah.
Oh, that's true. Yeah. It's been an exciting week though. Yeah, I guess I could report really quickly on some national stuff, because I did go to the last, PNHP Connecticut meeting, and also the one-payer states. And on the one-payer states front, there has been a Democratic a bill in the Senate introduced recently, Senator Markey, in the State-Based Universal Health Care Act, which just removes some of the barriers to states forming their own system. And Hawaii and New York and California, have all kind of gotten a certain distance with it. And Ro Khanna had a bill in the House for a few cycles, but Senator Markey from Massachusetts about a week ago introduced a bill. I don't think either of the Connecticut senators has signed on to it, although I'm not I don't know. I should look up whether there are some new co-sponsors. There weren't a whole lot of co-sponsors when it was introduced last Tuesday. I think it was April 2nd was when it was introduced, but it might be something to get in touch with. I can't imagine if Blumenthal is signed on to real Medicare for All acts that he would also support, the Sabuca approach. But so that is happening. And there's also a bill coming out of New York that would affect us, that would give municipal and state retirees who have been pushed into advantage plans the option of choosing traditional Medicare. And last I saw, it had four sponsors in the House, so it's not moving anywhere very fast. But they have been the PNHP group has met with Rosa DeLauro's staff and had a good meeting about it. I guess Rosa's healthcare aide, her dad died because he was in an advantage plan, and they denied him treatment. So, so they found a good reception there, not as good a reception in Johannes Hayes's office, which I thought was odd. I don't know the details. I don't know who met, and a couple of us in the second congressional district are trying to set up something with Joe Courtney. So I don't know. It's just beginning, but there are some things happening on the national front to slow the reach of privatizing Medicare.
So Connecticut state employees, by the way, including me, are in Medicare Advantage plan.
Including me, though it's through my
Yeah,
spouse.
Although, I mean, there are some of us, Rona, you should send me your email address or something, so we should talk. I've been talking to people in CSCA about getting rid of the Advantage plan when the contract expires in another 4 years. And there's a lot of people interested in that. It was done under the previous controller.
Right.
John Scanlon's, in the informal talks I've had with him, seems to be against Medicare Advantage plans. But that's something we need to really work on. We have a few years to deal with that. The difference in Connecticut is that the health benefits that we have under Connecticut under Medicare Advantage are identical to the benefits that we had before Medicare Advantage.
Yeah.
We were able to, the unions negotiated saying, do whatever you want, but we don't have any change in benefits. The difference has been in terms of bureaucracy, prior authorization issues with both United Healthcare and now with
Cigna.
Aetna.
Aetna.
And every time something comes up, we win it, but we shouldn't have to go through the BS.
And I think, when they changed from United Healthcare to Aetna, someone at the PNHP meeting brought up that every time they change someone's participating physicians might not work with it anymore. But I agree, our coverage is fine. My husband, he was a DMR worker in all through the 80s at in Southeast Connecticut. So when we retired,
I might have been
he
his
was
union
11
rep.
well, you might have been.
His union rep.
Yeah, he was 1199 all through the 80s into about when he turned 40, he got injured at work several times and he decided he was too old for the job. So he became a software guy. But yeah, the coverage is great. He had to have a hip replacement in early, in 2021, I think. And I think out of pocket, we didn't even pay $50. It was like one follow-up doctor's visit, he had a copay. So I can't complain about our coverage, but
the problem,
I'm not a fan of Advantage.
The problem is that newer retirees who don't know anything except Medicare Advantage don't see why we should get rid of Medicare Advantage because they think that's great benefits, right? It's no different than what we had when we had self-insured plan with Blue Cross, right? And it was self-insured. I administered it. And then we had a supplemental plan, which was also, self-insured. We paid all of those claims directly out of the state controller's office, right? And we kept track of all the data. One of the things I'm going to try to find out is if, in fact, the state controller's office is now keeping track of the non-traditional Medicare supplemental benefits costs, because that's really what drives, the benefits, the plans. But Aetna all these companies make huge amount of money from the federal government. That's why it saved the state money.
Yeah.
But sorry, I have to interrupt here. So I'm not really a part of this group, but it's much worse. I think it's way worse than what you described. I think that basically the prior author, it's not just paperwork. It's not just, it's affirmative denials. It's a systematic denial of claims,
Yep.
as well as a much
Yep.
smaller provider network than under traditional Medicare.
Right.
That's what your union negotiated to give away. It's not just the previous comptroller. The union offered this and said, we can save money by doing this without.
The network, any provider who accepts Medicare has to accept our plan, and they do. Yes, that's true.
No,
Yes, it
not
is
for
true.
Advantage plans, not for
Our-
Advantage
our-
No,
plans.
just the
employee
state
plan.
employees
Just the state
plan.
employees.
Oh, okay.
The
Oh,
state
okay.
employee-
Is a
That's what we
privileged
negotiated.
plan.
Oh,
It
excuse
isn't
me.
like
Okay.
other Advantage.
Oh,
So
okay.
that's why I said,
But by the way, you're
Okay.
right you're right in a sense, because we have to convince some providers who accept Medicare that they can accept this
Right.
plan and still get paid for it, right?
Exactly. Yes.
And we have
Yeah.
a process to do that. Basically, we call the controller's office, they call the provider and say, we're gonna pay you. So, which we shouldn't have to go through. So Sheldon,
Yeah.
you're right, I agree.
You still, but the prior authorization thing is a massive problem. And although the coverage on paper looks the same, that that's how they make money. The two ways is one, as you said, because they get overpaid by the federal
Right.
government because they managed to do all
Right.
that. And
Well,
then on the other end of it, they deny claims. And when you deny claims, guess what? Some people
But-
don't appeal. In fact, most
Right.
people don't appeal.
Right, but that money goes in another couple of ways. Aetna, we know, has at least 3 that I know of other organizations, any pre-authorization organization that they use. So they don't even do it in-house.
oh
So
my
they pay
gosh.
those organizations too. So they make a profit too. They're probably owned by, private equity firms.
They generally are.
Right,
That's
right.
another area
Yep.
they're getting involved in. Yeah.
Yeah. So anyway, that bill is starting to just show up. And that is something that we're hoping to talk to Joe Courtney about. I don't know, have no idea how he'll respond, but as I said, Rosa DeLauro's office was pretty sympathetic to it. I'm done.
Thank-
That's all I had.
Thanks, Rana. And it's 2
Thank
minutes
you.
of 8. So if are we all set now? Rana, you got all your federal and updates in there? I totally forgot about
That's
those.
all I had. So yeah, I'll turn off
Good.
recording.
Okay. Thank you, guys.